Thank you very much, Dr. Moran, for a very good update of a very difficult subject. Thank you very much. And I see Carla's joining us now. Can you hear us?
Yes.
Hi.
Yeah, can hear you.
Yes. Christine, can you join me up in the podium? So thank you both very much for a very interesting thyroid session. We have one question from one of our virtual attendees. And it's to Dr. Moran, I think. Yes, it says, in my center, we are getting large number of referrals for isolated low free T4 with no clinical hypothyroidism. What is the best way to make sure it is not an assay interference from the type used in our lab?
Yeah. So that is a really good question. And I think similar problems have arisen in the UK over the last year. And that was part of the reason why I included that case, because it's a really difficult situation, because like I say, we're worried that we'll miss adrenal insufficiency and central hypothyroidism, but actually most of the time these patients are going to have no thyroid disease and no pituitary disease. So I think if you're seeing an increased number of referrals, it would be worthwhile initially speaking to your biochemist, because the biochemist routinely should be looking at the free T4s that are falling outside the reference range. And they'll notice that if there's a slight assay drift and the mean T4 that they're returning is drifting downwards. So it might mean that the reference range for your assay is not quite right. So I think it'd be worthwhile initially speaking with your biochemist, and sometimes they might revise their reference range to one that seems more appropriate, and then that will get rid of some of those referrals for you. The other thing I think that's really important to remember is that many of these people who are referred to us with marginally low T4 will have normal physiology, and the free T4 will just naturally sit outside the reference range. So I think don't be afraid that if you've done some investigation and you haven't found any pituitary disease, and you haven't found, any other explanation for it, sometimes the explanation is just that this person normally has a T4 that sits at the lower end of the reference range. It's not often that free T4 is due to assay interference, actually. You can get negative assay interference in the free T4 assay, but it's not very common. It's much more likely to get positive interference, so falsely raised T4. If you are worried about assay interference in the free T4 assay, it might be helpful to just check it in a different assay. So perhaps a two-step assay, again, liaise with your biochemist. And if you get a free T4 reading on your repeat assay that's completely different, that would be a hint to me that that's free T4 assay interference in your first assay.
Thank you very much. Any questions from the audience? Yes, of course, Dr. Ria.
Did anyone stratify the level of TSI at the beginning for Graves' disease, let alone there is eye disease or not, to see what is the best modality of treatment? How high is the TSI?
So you mean?
At baseline.
Measuring TSI at baseline, does that help stratify treatment?
Stratifying to how high is the TSI and what is the best modality to treat?
Yeah, so what the NICE guidelines recommend is that you you recommend radioiodine for most patients except those who have low levels of TSI and not very severe Graves' hyperthyroidism. So I think, and what the evidence shows is if you have high levels of TSI, then it's highly unlikely that anti-thyroid drugs will work. You mean TSI for stratification of management of Graves' ophthalmopathy? Yes, so I think the management of Graves' ophthalmopathy, which I didn't touch on, it very much should be a management together with the ophthalmologist. So I run a clinic once a month where they're seen by the ophthalmologist as well, and we make a decision what are the safe treatment options here. So certainly we wouldn't give radioiodine in active Graves' ophthalmopathy, and we wouldn't give it in moderately severe Graves' ophthalmopathy. They very much like the TSI measurement there to help guide treatment. So if they think we could give radioiodine here under steroid cover, then we wouldn't do that in someone who has high levels of TSI. If we need a definitive treatment option in that patient, then that would be surgery.
And if she's planning pregnancy, you mentioned that radioactive iodine is preferred. However, the
Yeah.
TSI is not as effective.
No, so pregnancy, and again, I'll come back to that tomorrow when I talk about pregnancy. So radioactive iodine will actually raise the TSH receptor antibodies significantly. And when I have a nice graph for that tomorrow that shows how they come down following surgery, following anti-thyroid drugs, and following radioiodine, where actually they shoot up and they can stay around for many years. So I've managed a few patients now who actually been made hypothyroid by radioiodine 2-3 years after the treatment. So they're on levothyroxine but still have very high levels of TSI. Their baby gets fetal Graves' disease and it can be very, very difficult to manage. So that is a discussion to be had with the patient. So their pregnancy plans, and of course this is a condition that typically occurs in women of childbearing age who might be planning pregnancy. We would advise after radioiodine not to become pregnant within 6 months for radiation protection guidance, but TSI levels are very important, a very important discussion there as well. The way to manage that in pregnancy, I'll probably tell you tomorrow.
Some patients with Graves' disease may be having initially lowish WBC. So will you be concerned with starting them on antithyroid medication?
Sorry, the patient with Graves' disease?
Low WBC to start with? At baseline. Yeah, at baseline before starting them on treatment. Will you be concerned with antithyroid medication?
You mean to a level less than 1?
Yeah, it will lower it or it will improve it. I have seen patients, probably they may get
Okay,
better.
so again, similar to the liver function, you can actually get a relative neutropenia with hyperthyroidism per se. I think if the patient has a neutrophil count that's below 1 at the start, that makes me slightly more nervous. So again, similar to the liver function, there is no evidence that routinely monitoring helps, but that might be a patient where I say, let's start it and just monitor the blood count at least for a few weeks in this patient. And often they then have the first 2-3 weeks, a weekly full blood count by their GP to manage it. It can be difficult, so I've had a few of these questions in patients who actually are also undergoing chemotherapy, where we would expect them, of course, to get neutropenia. Often these patients are not in a position where you can quickly give them radioiodine or surgery because they're actively undergoing chemotherapy. And again, my advice to the oncologist is, well, monitor the patient as you usually would. And if the patient becomes neutropenic, it's probably the chemotherapy. But if they don't follow the usual pattern of what you might expect, then think about anti-thyroid drug-induced agranulocytosis. But they can be tricky situations. And again, ideally, you would use a different treatment option there if that's possible. But it all depends on the clinical scenario you're dealing with.
I know you're writing the guidelines. You do CPC on this line for the patient.
Yeah. So the guidelines, nice guidelines, which are very good, recommend baseline liver function, full blood count, and thyroid function. And then I rarely repeat it unless there is a clinical change. So it's based on clinical grounds that I would repeat it.
We have to show getting approved by the insurance.
To have a baseline full blood count? The American Thyroid Association guidelines recommend that as well, and the European Thyroid Association. So it is recommended by most experts. I think it's more because if a patient becomes neutropenic, you want to know what they start, or a patient gets liver function abnormalities, you want to know what you started with. And I think that's why it's a good thing to do. But yeah, I don't control insurance.
Christine, the last question regarding your first point, distinction between thyrotoxicosis and hyperthyroidism. Teaching medical students, we always tell them, sometimes it's a philosophical distinction versus a real thing that you need to know for management. Now, I thought the best way to distinguish it is to get the thyroid uptake and scan to really see whether the thyroid gland is functioning and taking up the iodine versus just the, high T4. So is that what you are indicating?
I think TSH receptor antibodies are the most straightforward test. A scan is more expensive. A TRAB level is quite a cheap test to do. Not everyone has ready access to isotope scanning, but if that's more easily accessible or paid back by insurance, then that is also a good test. But so I was mentored by someone who never believed in TSH receptor antibodies. So it's actually relatively late that in Birmingham we have come on board here. But I think the assays are now very good. So I think TRAB is good. So you mentioned TSI. I don't know whether you very easily have access here to blocking or stimulating antibodies. So certainly in the UK, all we get is TSH receptor antibodies. And to distinguish between blocking and stimulating antibodies is quite difficult and expensive in the UK, and we'd actually probably have to send to George Kahali in Germany if we wanted to do that. Because of course you can get, we see these patients where they are initially stimulating them, they become blocking, or vice versa. Cases of hashitoxicosis, which can be difficult to manage. And again, this may be anecdotal, but with COVID, I've seen many more of those. So again, I don't know whether infections sort of play a role in the way the propensity of these antibodies is. This is not scientific evidence I'm giving here, it's anecdotal evidence, but I'm certainly seeing many more, whereas usually I would see maybe 2 or 3 a year. I see them several times a month now.
Yes, Dr. Abdul-Jabbar.
Dr. Carla and a question to Christine. The question for Dr. Carla, the thyroid resistant, is it selective or it is universal in the body? Because we saw that there is a cardiac effect, but there is as hyperthyroidism, and on the brain it is as hypothyroidism. So there was underdevelopment, and there was what you have observed, that kids of that type of thyroid resistant, they were having developmental delay, the growth retardation and all these things. But on the other hand, they had cardiac arrhythmia and possibly they had different. So is it the ionotropic of the thyroxine which is acting on the heart and the other system, or it is the thyroxine itself which is being not resistant on that, so it is a selective thyroid resistant? That is one question.
Yes, so you're absolutely right in that these, the 3 syndromes that I described, RTH beta, RTH alpha, and MCT8 defects, these patients have a combination of some tissues which are responding to thyroid hormone and some tissues that are resistant to thyroid hormone. And the pattern of the sensitivity resistance is different for each of the 3 syndromes. So the patients with the RTH beta, sometimes they can actually have no symptoms at all, but you could think of RTH beta as being, some of the tissues are thyroid toxic, if you like. So the heart, for instance, seems to be thyroid toxic in some of these individuals because of the palpitations, the arrhythmia, like you say, and in severe cases, they can develop cardiomyopathy. So they seem to have a cardiac thyroid toxic phenotype, not quite as severe as we see in patients who have a common thyrotoxicosis and have normal receptors throughout the body, but kind of on the way there. So the patients with RTH beta, you can almost think if they're symptomatic, they'll kind of present a little bit thyrotoxic. Whereas the patients with the RTH alpha, because they don't have any excessive or increased levels in thyroid hormones, what they have is basically a lot of peripheral thyroid hormone resistance. So they'll kind of present like a hypothyroid patient, but then they have retained sensitivity in the axis, so that probably explains why the thyroid hormone levels themselves are normal. And the difference, I think, between the 2 of those really is that the RTH beta patients will have those high levels. So the normal receptor is responding to the high levels of thyroid hormone. And the reason those beta patients have the high thyroid hormone levels is because they have persistent TSH secretion, so it's constantly driving thyroid hormone production from the gland. So all of these patients have a conundrum of some tissues seeing too much thyroid hormone, some seeing too low a level of thyroid hormone. And that's why it's so difficult to treat, because really we're trying to balance things. We're trying to give the tissues that need more thyroid hormone, and we're trying to reduce the effect of thyroid hormone in other tissues, for example, in RTH beta in patients with cardiac thyrotoxicosis. And the medications that we use at the moment are either antithyroid drugs or they're thyroxine. So they're not going to be tissue selective. And so what we do clinically is we assess them and try to decide what is bothering this patient the most. So the first man I showed with the cardiac thyrotoxicosis and RTH beta, I mean, his cardiac effects were very pronounced, and his heart really needed a lower level of thyroid hormones. That's why I gave him an antithyroid drug. But that will mean that the other tissues will also be seeing a lower level of thyroid hormone, but I think that's kind of just the price you have to pay for ensuring that his heart is in a happier state.
All right, thank you. Now, just what I wanted to say about the thyrotoxicosis in kids, in children. My own experience, I had over the last 35 years, maybe 20 patients with thyrotoxicosis in kids. Most of them, they have responded to treatment. Only one who did not respond. And usually we were treating them for 2 years with carbimazole, not with PTU, because they are not pregnant. And okay, so PTU usually is reserved to the pregnant lady who has hyperthyroidism. But for the kids, we were using carbimazole. None of them, they had any side effect from the what we call it, from the face of, say, agranulocytosis or things like that. And only one patient that I remember that I referred for iotropic agent treatment, and that was because the child presented to me at age of 2.5 years with thyrotoxicosis very early and remained thyrotoxic until the age of 16. So for that reason, and she was not compliant, and she was with frequent relapses. But most of them that we treated, they were good, they had a good compliance, and there was no relapse at all. So just to share the experience, that in kids, possibly thyrotoxicosis is more benign than what you see it in adults. The second thing, that when they present with exophthalmos, usually in kids, they respond very well, even with the carbimazole. I know that the physiology and the pathology are different, but none of them remained with the exophthalmos. All of them, they had just normal eye feature later. Just to share with that the experience that I had.
Okay, well, thank you for sharing that experience. So your experience is at odds with what most people see. So Graves' disease in children can be very, very difficult to cure, and the published data are that only about 25% of them are cured. I agree that for most of those children, we continue antithyroid drugs for longer, because surgery is more invasive and because there are still concerns about radioiodine in using it in certainly prepubertal children. The few data we have on radioiodine in children is that it's safe. The NICE guidelines do recommend for children that you continue antithyroid drugs if they're not cured after an initial course, but that you consider definitive treatment options, certainly in post-pubertal children. So with regards to Graves' ophthalmopathy, again, I would agree so obviously Graves' disease is much rarer in children. Graves' ophthalmopathy is even more rare. As it happens, I had a Zoom call yesterday with the pediatricians in Birmingham, because we now have 5 cases of really very severe resistant Graves' ophthalmopathy in children, 2 in prepubertal, 2 in postpubertal children, 2 and 3, where we're discussing, how to go about giving them biological agents But until, I generally don't, I'm not allowed in my hospital to treat anyone below the age of 16. So I generally don't treat them. But again, there seems to be, I don't know whether it's coincidence, but it certainly seems to be on the rise, is what the pediatric endocrinologist in my area tell me. I presume that we get quite concentrated from over the whole of the West Midlands. But so there seem to be some children there with very resistant Graves' ophthalmopathy.
Thank you. There is one final question. It's related to treatment in pregnancy. Switching to PTU, and then whether we switch back to carbimazole after the first trimester.
Okay, so I'll come back to that tomorrow. So if I know a patient is going to become pregnant, then of course I work in an area where about 50% of pregnancies are unplanned. But if I have the luxury of knowing that they're planning pregnancy, then I will change to PTU before they start trying. It depends what time they present to my clinic and how severe. So if possible, you stop anti-thyroid drugs. So if their thyrotoxicosis is well controlled, you could stop anti-thyroid drugs. Graves' disease generally gets better in pregnancy. Some people stop if they're on carbimazole, they just stop it altogether in the first trimester, and actually often by the second trimester, it gets better. I still usually change from carbimazole to propylthiouracil. Certainly if they come very early to me. If they're already at 12 weeks, then I just continue on carbimazole, but actually for most patients, I just try to stop it as soon as possible. New onset, and again, I'll come back to all that tomorrow. So new onset Graves' disease in pregnancy is very, very rare. If you have thyrotoxicosis in pregnancy, that's usually gestational thyrotoxicosis, but hopefully this question will also be better answered after my slides tomorrow.
Thank you very much. Christine, Carla, thank you very much for we wish you were with us here in Bahrain. Maybe next time.
Me too.
I wish I was too. I'm looking at a very rainy Dublin. It's not very nice.
I'll
Next
send you a
time,
picture.
Right. Thank you very much. Christine, I want to give you your certificate here.